Hi everybody. I will take about our diagnostic procedure in primary care. Of course, everybody considers that it must be evidence-based, it must be precise, it must be valid, it must be reliable. But when we talk about the real evidence behind this, we cannot say the same thing. This is a room of an old medical school and medical faculty in Mazicioglu, which was built more than 100 years ago. A famous architect of Turkish writes a poetry for this room, which is in Japan style. In the first line you use 5 syllables, in the second line 7 syllables, and in the third line 5 syllables again. It says, dimensions or light that creates the place. Which one shows us the place? In our diagnosis, the first step is to make, we are trying to make precise diagnosis. For example, in the measurement of blood pressure, in our machines we have 2 millimeter mercury standard error. If we measure my height, you has 1 millimeter standard error. Even if you make everything in order, everything is complete, we have a standard error in our measurements. And I want to ask you, does any of you know a 100% valid sign or symptoms for a certain disease? For example, is high blood pressure is a 100% valid diagnostic criteria of hypertension? I may have low, I may have depression. Most of diseases are diagnosed with more than one parameter, and we have to multiply the error rates. If we have 3 parameters and we have 5% standard error, 5 times 5, 2% error, 2 times 2, 4, 2 times 4, 8. In the end, we have 8% standard error. In the laboratory, pathology, radiology, and clinical laboratory, we have about 2 to 5% error, standard errors. The remaining error, more than 90% of our errors are related with sampling and transport of these samplings to the laboratory. If we take an orange and make 3 sections, if we make this one, we can say that orange has 8 small slices. But if we make the section like this, then we can say that it has 2 slices. If we make an oblique section, we can see this. If we don't know anything about orange, then it is not easy to describe a fruit named orange. All of our measures, most of our measures in our diagnostic procedure now depends on quantitative research results, but we must have qualitative research results also to decide precisely about the diseases or illnesses that individuals have. Steve Jobs says, "I think the biggest innovation of the 21st century will be at the intersection of biology and technology. A new era is beginning. Now we are heavily rely on electronic equipment to make diagnosis, and we are trying to cure the electronic equipment also. We are looking at the monitor and prescribing. We are not prescribing to the patient, but we are prescribing to the monitor. And in certain diseases or in certain conditions, like alcoholism or normal drinking, what is our cutoff point? How we can say that it is normal drinking or alcoholism? It is also the same in depression and sorrow, euphoria and hypomania to full-blown mania. Some psychological conditions are described as illnesses or diseases, like adolescents, elderly nowadays, and we are increasing these situations, but it is not easy to describe these situations. Discrimination is very difficult. For example, I tried to find out a precise formula to describe drinking alcohol. 1 unit of alcohol is equal to 40 milliliter of Turkish rakı. You multiply the volume by the percent of alcohol and divide by 1,000. Then 40 milliliter of rakı is equal to 1.8 units. We have conditions like shortness. People want to use growth hormone for shortness. We have newly described diseases like hyperactivity disorder. We are using drugs for these disorders, which may have severe adverse effects. Inducing pregnancy in postmenopausal women is another treatment. And American Psychiatric Association deleted homosexuality from their disease list in 1973. Like masturbation was a sin 100 years ago, but it is considered as normal now. Then can we use this description for the description of health state? Health is a state of complete physical, mental, and social well-being, and merely the absence of disease or infirmity. This was made by WHO. On the other hand, private insurance pays for genuine diseases, which they call abnormal. What about cosmetic surgery, abortion, nicotine addiction, and impotence? Some conditions are described as disease. Heroin dependence is an involuntary ill state, but pregnancy is a voluntary ill state. Physical, emotional, physiological, familial circumstances, and woman's age may be related with health or unhealthy. Can we describe mental diseases? Are criminal insanity or not? In 1967, an American scientist sends about 20 healthy people to several hospitals in USA. All of them are healthy, but each of them says to the doctors that they are hearing some sounds around, although there is nobody around them. That was just a symptom. When they all say this to their doctors in the hospitals, nearly all of them were hospitalized, and just the other patients in those hospitals considers that they may be normal. You do not look like us, but you are here. Why? The other patients ask to these people to check that if anybody gives positive symptoms to the doctors, if doctors are diagnosing them as ill. In some diseases, like the sickle cell trait, if we are not homozygote sickle cell, if we don't have homozygote sickle cell disease, we have just one trait, then we are not ill. But shall we consider us ill or healthy? It is the same in the BRCA gene for breast cancer. Is there a disease and treatment coexistence? We have values. Some values in some countries consider diseases as normal conditions, and in other countries it is not considered as a normal condition. There is a study made in USA in which common presenting complaints of patients who experienced a diagnostic error. In the first 5 lines we can see abdominal pain. The second one is fever, then fatigue, then dyspnea, then rash and cough. For the same sample, if we look at the incorrect diagnosis, we see benign viral infections, musculoskeletal pain, COPD, benign skin lesions, and urinary tract infections. Finally, when we have the precise diagnosis, we have cancer in the first line, pulmonary embolism, coronary artery disease, aneurysms, appendicitis in the 4th line, and Kawasaki disease in the 5th line. Then can we rely on our diagnosis even we are using quantitative methods? Then what to do? We can make a proposition for these things. First, as it was said by, as it was presented in the morning, we have to listen to our patients first. We have to shut up and listen to their symptoms and signs from them. But we don't, they mustn't convince us. In Turkey, people come to you to get a certain prescription, to get a report for sickness leave. So they mustn't convince you. If we try to explain everything to our patients, if we talk about the etiology, if we talk about the diagnostic methods, and if we talk about the probable therapy, then we are increasing their demand to the diagnostic methods, to the therapy. So we have to limit everything. We have to limit our explanations both in the diagnostic period and during the therapy. This may change our way of communication with the patients. The paternalistic model was turned into interpretative model nowadays, but perhaps we will change to the deliberate model, in which we will tell the patients the limited details and ask their preferences. This change can lead several problems. One of them is underestimation of the signs of symptoms for a certain disease, which is our failure, diagnostic failure. If we talk more about certain things, then we can make overestimation. This will lead over-attention in patients. Social security doesn't pay the scientific things sometimes. You make your research and find that something can be used for a certain disease or an illness, but Social Security says I am not paying this. We have to reshape our curriculum considering the overestimation, underestimation, and Social Security sanctions. And this contemporary medical practice may not be easy to follow. We may change our curriculum more than its medical context, but we have to rely on law, communication with the patients, communication with the other doctors, and etc. I want to give an example about the precision of diagnosis in primary care with a quantitative method. If we have a pathologic criteria, gold standard to diagnose hepatitis C, and we have another serologic test, we have true positives, false negatives, and true negatives. In this case, if we can diagnose with this serologic test 25 hepatitis C patients with 5 false negatives, our test sensitivity is 83%. When we look at the specificity of our diagnosis with this serologic test, it is 93%. But if we have the prevalence 3, for 83% sensitivity and 93% specificity, we have the positive predictive value of 25%. If we have a very low prevalence. But if we have same sensitivity and specificity in our test, but increase the prevalence to 12, we have 83% sensitivity, it is not changed. We have 93% specificity, it is not changed. But we have increased the prevalence. In the previous prevalence, the prevalence of 3%, we has 25% of positive predictive value, but now the positive predictive value goes up to 61. If we consider that all of the illnesses or most of the patients are coming to our office when the prevalence is very low, at least we have to see them more than one time to get a precise diagnosis or to increase the positive predictive value of our diagnosis. There are publications about overdiagnosis, overuse. Many of them are published in the last 10 years, and we have these terms, the overdiagnosis. The second one is overutilization of the institutions, overutilization of the doctors, overutilization of the health personnel. When the patients overuse these institutions and stuff, then we start over-treatment and over-medicalization, of course. Together with these things, we have also misdiagnosis, misuses, and disease monitoring and low-value care. It depends on our education, it depends on our effort. In 1860s, an English doctor says that we can make prevention for certain diseases and prevent them before they become a disease, we can benefit a lot. This goes to France 10 years later, and in 1906 in United States, they consider that if they make an initial examination for the people before they start their work, they can take much more healthy people, and they will benefit also. About 10 or 15 years later, banks and insurance companies start to publish guidelines which symptoms and signs should be checked by doctors to work here or to make health insurance or etc. But in 1920s, in 1960s, in 1980s, several scientific publications says that there is not a difference between preventive measures or not, other than some very prevalent diseases like tuberculosis or malaria. Even omega-3 fatty acids, use of omega-3 fatty acids, and use of eggs to prevent cardiovascular diseases or diabetes were studied. For example, this study is about the use of egg in diabetic people. If for men eat more than 5 eggs in a week, or women eat more than 7 eggs in a week, they will increase their cardiovascular disease risk if they have type 2 diabetes. And another study was done last year, which concludes that the score chart that we are using very frequently in the last about 20 years was not checked by any systematic review or meta-analysis if it is working or not. It is our main criteria to give morbidity or mortality about cardiovascular diseases in the last 20 years, but there is no big study, systematic review or meta-analysis which says that it is working or not. Perhaps it is working, I hope. Then how can we describe normal and not? If you are a mathematician, if you are in the Department of Biostatistics, you can use the Gauss distribution. As we did, the percentages are also similar to Gauss distribution. In children, we are using percentages to monitor their growth and development. Culturally, some diseases or some conditions can be defined as disease or illnesses. We can define illnesses as risk factors. Having risk factors like sickle cell trait can be a disease. Or we can use cutoffs like 126 milligram deciliter blood sugar gives us the diagnosis of diabetes. But we must be sure that in each cutoff we have false positives and false negatives. Robert Taylor, the writer of a family medicine textbook, says, in my opinion, medical wisdom is the capacity to understand and practice medicine in a common sense manner that is scientifically based, sensitive to patient needs, ethically grounded, and professionally satisfying. And Francis Bacon says so. What is the problem? The other that he shall have counsel given, hurtful and unsafe, though without good meaning, and mixed partly of mischief and partly of remedy, even as you would call a physician. That is thought good for the cure of the disease you complain, but is unacquainted with your body, and therefore may put you in a way for a present cure, but overthrow your health in some other kind, and so he cure the disease and kill the patient. I found a book about the guidelines in primary care. There are more than 23 groups of guidelines. You can see them. Guidelines about mental health, guidelines about gastroenterology, guidelines about cardiovascular diseases. There are many guidelines, and in each 3 year, in each 5 years time, these guidelines are changing. Today we talked about, in the morning sessions, we talked about blood pressure. And the cutoff point for the blood pressure here was given as 135 for systolic and 89 for diastolic pressure. But in Turkey, we are using 120 and 80 as systolic and diastolic blood pressure. No two guidelines are the same. And each disease have an interesting topographic structure. For a certain disease, we can talk about exogenome, epigenome, microbiome, metabolome, proteome, transcriptome, and genome. All of them are related with the same disease, and each part of the researchers in these sections considers that their section is the most important part in the management of that disease. Thanks God, a 3 months long and about $5,000 cost genetic analysis were now can be done in a couple of days, and about 300. If you give $300, you can get a full profile of your genetics. But in genetics research, it is said that about 3% of genetic material is hidden in the centromere and the telomeres. Even in full genetic profile, you cannot see 3% of the genes, and 3% of genes corresponds about 900 genes. For a one causative variant in a gene, we have 3.5 million genomic variants. It is not easy to diagnose using genetic tests. I talked about this study. in conclusion, it says supplementation with energy fatty acids did not result in a lower incidence of major cardiovascular events or cancer than placebo. I used more than 10 years of my practice telling about people that if they transfer their use of fatty acids from N6 to N3, they will benefit for their cardiovascular disease and even their intelligence will increase. And there are studies about the drug companies which says for the common condition study, a majority of panels proposed change to disease definitions that increase the number of individuals considered to have disease. None reported rigorous assessment of potential harms of that body, and most has a majority of members disclosing financial times to pharmaceutical companies. And about the guidelines, effect of clinical guidelines on medical practice, in a systematic review, it is concluded that explicit guidelines do improve clinical practice when introduced in the content of rigorous evaluations. However, the size of the improvements in performance varied considerably. And finally, we can say that randomized trials are largely done by and for the benefit of the industry. Meta-analyses and guidelines have become a factory, mostly also serving vested interests. National and federal research funds are funneled almost exclusively to research with little relevance to health outcomes, and we have supported the growth of principal investigators who excel primarily as managers, absorbing more money. In salami sliced data, direct articles with gift authorship, and has become adapted to dictating policy from spurious evidence. Under market pressure, clinical medicine has been transformed to finance-based medicine, and in many places, medicine and healthcare are wasting societal resources and becoming a threat to human well-being. As Francis Bacon said, cure the disease, kill the patient. Thank you very much.
Thank you very much for your interesting presentation. You give us really something to think about when we will be back on Monday in our offices. I think that the main question would be, is our patient ill or is it not? Thank you.
I want to give another explanation. This study calculates the number of years that we benefit if we make regular exercise. And this is the time that we use for a regular exercise. We are using about 2 or 3 years to make exercise, to live a couple of years more, and we are gaining a couple of years.
Thank you.